Good morning all, and thank you for joining today's session. My name is Amanda Willicott, Programme Manager for the Value in Health team, and together with my colleague Dr. Rob Palmer, in today's session we'll be giving an introduction to PROMs and PROM scoring. In addition, Rob will discuss some considerations when putting a data set together in readiness for analysis. Next slide, please. So value-based healthcare is realised when we achieve the best possible healthcare outcomes for our population in a financially sustainable way. The value-based health approach focuses on meeting the needs and the goals and the preferences of patients through involving patients in decision-making. This decision-making needs to be supported with the best information and evidence that we have. So, we see outcomes as the important milestones in the lives of patients that matter to them, so we do need to measure this. So a key element of the Value in Health approach is to electronically collect patient-reported outcome measures routinely and at pace and scale. And it's important to embed the collection and the utilisation of PROMs as business as usual. Next slide, please. So what are PROMs? PROMs are standardised and validated questionnaires completed by the patient which form a structured assessment to measure patients' perception of health and functional well-being. PROMs can be completed before and after treatment or over time to determine if there's been a change in the patient's condition and health-related quality of life. The questions are designed and tested with patients and clinicians. This is either for specific conditions or for general health and health-related quality of life. And specific and general PROMs can be used together to gain a broader picture of the patient's health status. So next slide, please, and we'll discuss a bit more detail around these different PROMs. So, condition-specific PROMs ask questions specific to a given condition or disease. They focus on a specific area of health, so are very detailed and therefore sensitive to changes. The level of detail makes them particularly useful to clinicians in order to understand their patient problems and therefore can be seen as a tool to help personalise care. And then, as an example on the right there, general quality of life PROMs measure overall well-being and can be used to compare between different conditions. So, for example, between knee arthritis and heart failure, or within the same condition area. So they can be used in clinical and cost effectiveness analysis, and this makes them useful to compare costs and outcomes of different treatment. But general quality of life PROMs are not so sensitive to monitoring disease-specific changes. Next slide, please. Excuse me. So I have already mentioned that the Value in Health approach places the utility of PROMs at the heart of its vision, to provide timely information and to inform decision-making at all levels. And there are key data products which are being developed to support this vision. So firstly, an important use of PROMs is as a tool to support direct care, and data visuals shown at the top of the screen are being created in the patient's electronic clinical record to facilitate this. You can also see at the top of the screen a list of ways PROMs can assist with informing individual care. So for example, it can help provide a structure to a consultation and act as a symptom tracker or needs assessment. It allows patients to consider what matters to them most before a consultation and can help patients to consider issues they may not have previously thought as relevant. It can also help facilitate the discussion of difficult or sensitive issues, as well as that two-way exchange of knowledge and decision-making. So relevant in our current environment, PROMs can assist with more flexible ways to deliver individual care. And we have seen this over the last 2 years. So for example, PROMs can be collected prior to and used to enhance that video consultation. We have also seen PROMs used to support remote monitoring following treatment, and also by giving patients flexible access to record outcomes. This can enable patient-initiated reviews, and so the patients are then seen on symptoms or when a condition flares up. On the lower half of the slide, we can see that aggregated PROMs data can be brought to life in dashboards. And then if we combine this patient-reported clinical outcome and case mix data together, this can assist in a number of ways to improve care. So for example, with maybe identifying low value practices and assist with relocating those resources into high value interventions. By identifying good practice and reducing unwarranted variation in care. And also being able to assess population needs and understand whether those needs are met. Now, there will be observations and insights from the data presented in the dashboards, and this may lead to some bespoke analysis to help answer further queries. So there are many ways that PROMs data can be used, and with all this in mind, if colleagues are starting to use this data for the first time, it is essential that consideration is given to how the data collected will be initially analysed. So next slide, please. I will now pass you over to my colleague, Dr. Rob Palmer, who will introduce himself and discuss PROMs analysis in more detail. So over to you, Rob.
Thanks, Amanda. Good morning. Yeah, I'm Rob. I work for CEDA, which is a health technology research centre based at Cardiff and Vale University Health Board. So what I'll try to do in my half of the session is to point out some things to consider when going about analysing PROMs, maybe for the first time. So I'll be showing examples of some different types of PROMs data, as well as some examples of how to score different PROMs questionnaires. And also point out some things to consider when starting aggregated analysis. So what I mean by that is we're not looking at PROMs by a single patient in isolation, but we are looking to quantify the health state of a group of patients, maybe with the same condition or the same treatment, or to compare groups of patients together. And that will be the main focus of my bit of the session today. So I should point out that the examples that I'll be showing are for acute conditions or for conditions where patients will receive elective treatment. That's because chronic conditions are a lot trickier to analyse, but I hope that will become more obvious as we go through the slides. So I'm not a statistician, so I won't be talking about different statistical methods for analysing PROMs, but what I will be talking about is making sense of PROMs data and things to think about when putting the data set together out of the collection system that we're using. So analysing PROMs is quite a big topic, and the approach we take depends on lots of things, and it can be hard to generalise. So what I've done is I've got a lot of running examples through the slides, which I hope you'll find useful instead. Go to the next slide, please. So just a quick reminder of what PROMs are then. So the questionnaire is given to patients, and they ask questions on patients' quality of life and symptoms. And they usually have a series of multiple choice questions, and these answers can often be represented by an overall PROM score. So these scores give an overview of the patient's responses, kind of like a summary score, which makes it easier for us to analyse. So most tools have a scoring algorithm to convert the multiple choice questions into an overall score. And the algorithms for different tools are all different. So some PROM developers or PROM owners will provide us with a piece of software, such as like an Excel macro or via a website maybe. We as analysts can upload our PROMs responses and they'll return the PROM scores for us. But it's much more common for the developers to provide us with a scoring manual, which is usually a PDF document with instructions on how to go about scoring our own PROMs. So I have 3 PROMs scoring examples now to show, which hopefully they'll show the differences between the different type of scoring. The first one there is on the screen. So this is the first example is the EQ5D5L. It's a popular generic health prom developed by Euroqual, and it has 5 questions or dimensions, which is what the 5D stands for, and it has 5 answer options for each question, or 5 levels, which is what the 5L stands for. And I've just randomly chosen some answers there for the purpose of this example. Have the next slide, please. So to score this, the developers have provided us with some instructions. Oh, sorry, could we go back to the previous slide? Thank you. So to score this, the developers have provided us with instructions on a lookup table. So in this example, the patient has answered with answer 1 for questions 1 to 3, answer 2 for question 4, and answer 4 for question 5. And this gives us an answer profile, or something called an EQ5D profile of 11124. And then looking at the lookup table, we simply look for the profile in the profile column, and then we go across to the UK column as we're in the UK, and that gives us a score called an EQ5D index of 0.537. So the lookup table was created by the developers by interviewing patients in different countries, and the reasons why there are different value sets there for different countries is because the perception of the quality of life changes in different regions. So in terms of scoring this prom, there isn't much work that we need to do really. It's really straightforward because the lookup table basically does it all for us. We just need to work out what the profile is and then look at the score in the lookup table. So if you have the next slide, please. So the next example is the Oxford HIP score. And this is a HIP specific prom, which has 12 questions, and each question has 5 different answer options. And the first question is there on the slide. The scoring manual, this again comes as a PDF document, and in the document it tells us that the overall score can be reached by simply summing the scores received for individual questions. It also tells us about how to deal with missing answers, and it says that if we have 1 or 2 missing answers, then we can take the mean of the answered questions to fill the gaps, and then carry on taking the sum of all of the questions to get the overall score. But it also says that if there are more than 2 missing answers, then the score should not be calculated. So it's quite detailed. It tells us how to deal with the missing data there, and there's no further questions for that. So some manuals do mention the missing data, how to deal with missing data, but some don't. And sometimes the information on how to deal with missing data can be hidden away in the document, maybe on a different page. So it's always worth a thorough look through the scoring document before we jump in and start scoring the proms. So the next slide, please. So the last example I have is the EORTCs, or the European Organization for Research and Treatment of Cancers, QLQ C30. And this is a cancer prom with 30 questions. And I think, 5 of them are there on the slide on the left. So this one is very different to the previous 2 examples, where the previous 2 examples used all of the answers to the questions to create one overall score at the end. But in this prom, there isn't an overall summary score, and instead there are sub-scores. And these sub-scores are used to basically summarize subsets of questions in the prom. And these subsets then represent different themes, for example, physical functioning, emotional functioning, or fatigue, and so on. So in this scoring document, they actually use the term scale for score, which might make sense in the coming slides. And for example, in the table there, at the top of the table, the QL2 scale only uses questions 29 and 30, and the PF2 scale underneath it only uses questions 1 to 5. Also with this prom, there are different scoring equations for the different scales. So if we were going to calculate one of the functional scales, which is one of the scales underneath the orange heading in the table, we'd use one particular equation. You can see that at the bottom of the slide underneath the table there. But if we were going to calculate one of the symptom scales or the global health status, then we'd need to use a different equation. Again, this scoring document tells us how to deal with missing data, and again, it was on a completely different page to the rest of the scoring instructions, so it's definitely something to watch out for. So what I wanted to show from these examples is that basically each scoring method or algorithm can be different for every prompt tool, So some are simpler, some are a lot more complicated, but generally they're all very different to each other. Just go to the next slide, please. So I'll just quickly mention common types of data in PROMs. So the majority of individual questions look like the two examples there on the left. And these are like-it items. So like-it items have specific definitions, which I won't go into because I can never remember them all. But essentially, they are ordered multiple choice questions. So you can see the answers to the question there are ordered in terms of severity. So for the second example there, we start with none and we end up with severe. So the two extremes are at either end, and usually there's a neutral answer in the middle, which means that usually a like-it item will have an odd number of answer options. Any ordered multiple choice question that isn't like-it, so it doesn't meet the like-it item definition, is called an ordered category item. And there's also like a weird grey area where some questions are described as like-it type items. So they agree with some of the like-it item definitions, but not all of them. So there are subtleties between these different types of ordered multiple choice questions, but it's quite complicated and I won't try to go into it. But generally, we should treat this data as ordinal data, which basically means we should stay clear of averages. So for example, if we had lots of responses to the second example on the slide there, and we ended up with a mean of 3.34, say, well, there's no label there to match a value of 3.34. So that value of 3.34 is essentially meaningless. We can kind of think of this as we can replace the 43210 there with A, B, C, D, E. So taking averages doesn't really make sense. So it's much safer to report frequency count and histograms for each answer and that kind of thing instead. So I don't have an example on the slide there, but we may also come across a visual analog scale or a VAS. And that's where we mark the scale. We ask the patients to mark on a scale how they feel on that day. And the scale usually runs between 0 and 100, where 0 usually means worst health imaginable, and 100 usually means the best health imaginable. This data we can usually treat as continuous, as long as the data meets the usual stats criteria. So on the right-hand side of the slide there, I'll start talking about PROM scores now. So PROM scores are usually a combination of the answers to individual questions. And it's rare to see a visual analog scale or a VAS in the makeup of a PROM score. It's usually just the ordered multiple choice questions that we can see on the left there that make up the PROM score. So if all of the questions in the score that make up a score are like-it items, then we'll end up with something called a like-it scale. Any other combination of ordered multiple choice questions will end up with a summated rating scale. So again, there's subtleties which I won't go into, but what I will say is that there's a big debate on whether these scales or these scores should be treated as continuous data types or not. So this is important because whether these scales can be treated as continuous or not determines whether we can take averages of these scores or not. So there's no obvious consensus, which means there's no obvious right answer on how to deal with this type of data. But luckily for us, there's no obvious wrong answer either. So in the PROMs world, generally averages such as means and medians and so on are calculated for PROM scores, but there's always a risk that some people might not agree with what you've done. So the next slide, please. So before I talk about aggregated analysis, I'll just quickly comment on patient level stuff. And basically, it's hard to go wrong. So with patient level analysis, we're essentially looking at PROMs by a single patient, probably over time, maybe throughout the patient pathway, for example. And we see this type of analysis in data dashboards or electronic patient records. And it's really useful to monitor the patient to see how they are doing with time. And it can help in the clinic to discuss the condition with it can help the patient to discuss their condition with the patient over time. But all we can really tell from this type of analysis, and all we're really interested in, is has the patient improved with time, yes or no? So a chart like this can be useful, and we can generally see if a patient's getting better or worse with time. And we saw some real examples of this type of thing in the PROMs visualization session yesterday afternoon. We might be interested in knowing how much a patient has improved, but that's only useful if we know what that value means. So for example, we could calculate that a patient has improved by 6 between one time point and another. But if we don't really know if that value of 6 is good or bad. We'll only know what that value means if we look at that value in relation to the values of other patients. So for example, we might want to compare that value with a specific threshold, such as a minimal clinically important difference. Or we could compare it to the values of other groups of patients, perhaps with the same condition or the same treatment. So the next slide, please. So as soon as we start talking about averages and groups of patients, we kind of cross over into the aggregate analysis of PROMs then. Basically, aggregate analysis when we look at PROMs from multiple patients, and perhaps to describe the state of play of that cohort. So we may also want to compare the responses of more than one cohort of patients, perhaps to compare different conditions, treatments, procedures, or patient demographics, or for benchmarking clinicians, departments, hospitals, or even countries. Go to the next slide, please. So aggregated analysis can be used in a number of different study designs. So the prospective study design is when the research question comes first and the data collection design comes afterwards. So after coming up with the research question, the decisions on which data to collect and the way that data is collected is designed specifically to answer that specific question. So this could be experimental and highly controlled, such as a clinical trial, or it could be observational, where we don't change the patient's care anyway, we're just observing what's going on. But in all cases, the data collection was designed specifically to answer that question. So we could say something like, we want to answer this question. In order to do that, we'll collect this specific PROMs data in this specific way so that we can answer that question. So the next slide, please. With a retrospective study design is essentially the opposite. So the data collection design comes first and the question is thought of afterwards. So the decisions on which data to collect and the way that data is collected was made in the past, possibly or probably before the question we want to answer was even thought of. So the data is usually collected in the past, but that doesn't always have to be the case. So the data could actually be collected now or in the future, as long as the decisions on data collection were made and agreed in the past and can't be changed now. So in this case, we could say something like, here's a bunch of PROMs data we've collected over the years. It looks like there's enough there to do something with it. Why don't we try and answer this question with it? So retrospective study designs are usually observational, so we're not influencing the patient's care in any way. So in an ideal world, we'd probably like to have a prospective study design in all cases, because then we'd end up with the best data to answer the specific questions. But unfortunately, that would mean that we'd have to collect new data for every single question we want to answer, which is, well, it's impractical and probably will be very expensive. So in reality, most PROMs analysis is retrospective. So we collect a bunch of data with the hope of answering lots of useful questions further down the line. We just haven't thought of those yet. So the reason this is important is because analysing data from a retrospective study design usually means much more work than analysing data from a prospective study design. So with prospective study designs, there's less chance of needing complicated data linkages and complicated data cleaning, because that might have already been taken care of when we design how we collect the data and what data we are going to collect. But there's much more to think about with analysing data for retrospective study designs. So because retrospective study designs are much more common, it's what I do most of the time, I thought I'd focus on that for the rest of the session. Go to the next slide, please. So as I said, I won't be talking about stats, but I will be talking about getting the data ready to be able to do the fancy stats stuff later on. So things to think about would be the question that we're trying to answer. What additional info apart from PROMs do we need to be able to answer that question? How does our collection system actually collect PROMs from patients? And finally, which type of analysis do we need to do to answer that question? So in a retrospective study design, the first 2 points there tend to go hand in hand and they directly influence each other. So I'll cover these together on the next couple of slides. So the next slide, please. So we could ask something like, is there a difference in average scores between the first PROM and the last PROM that patients completed? Sorry, can we just go back a slide a second? Thank you. So on the face of it, this looks like a sensible question because it might give us an idea of how patients have done between completing their first and last PROM. But what if patient A completed the first PROM before surgery and patient B completed it after they had surgery? Well, that means that we won't be comparing like with like. Let's go to the next slide, please. So more useful questions might be, is there a difference in the average scores of patients with different BMI at referral? Is there a difference in the average scores of patients of different ages after surgery? Or is there a difference in the average PROM scores after 2 months before surgery and 6 and 12 months after surgery? So these questions all ask us to look at PROMs in relation to clinical events, such as surgery or referral. And so that means there'd be more of a chance that we'd be comparing like with like, and makes the analysis more clinically relevant. So we immediately need additional information here, such as referral and surgery dates, to be able to answer this question. Now, we probably won't be asking patients to give this data alongside the PROM, so we probably need to look for surgery and referral dates and so on somewhere else. And just quickly, we might also want to look at the difference in PROMs between different demographics, such as BMI or ages. And again, we might need to look somewhere else for these two. So for the rest of the presentation, I'll be referring to pathway events such as referrals, admissions, surgeries, discharges, and follow-up appointments as anchors, because they kind of tie the PROMs together for us to make more sense of the data. Let's go to the next slide, please. So to get this extra information, we probably need to link to other admin or clinical data sets. So things to think about are hospital and patient IDs, to make sure that we link in the right PROM to the right patient. Clinical codes and anatomical area to make sure that our anchors, such as referral or surgery, is for the correct condition. So many patients are on multiple pathways at the same time. So for example, if we have an Oxford hip score PROM, we want to make sure that we link that to a referral for a hip arthroplasty rather than a referral for cataracts. The next one is often forgotten about, but I think is very important. So we'll also want to consider the anatomical side, so as in the side of the body. So for example, patients may have surgery on their left hip as well as their right. So we want to avoid linking a referral for treatment on a patient's left hip to a PROM where the patient was filling it in about their right hip. And finally, we may want to consider whether the referral or surgery was for a primary procedure or a revision, and which of these did the patient consider when completing their PROM. Let's go to the next slide, please. So I'll move on now to something I think is one of the most important things to consider, which is how does our collection system or collection process actually collect PROMs from patients? So we may receive a data set that looks like this, where we have one row per patient, and we have columns with PROM responses and dates at one time point. So for example, pre-surgery, and columns with PROM responses and dates at another time point, for example, 6 months post-surgery. And we might also have some additional info to help us answer our questions. If our data doesn't look like this already, then we'll probably be looking to rearrange it into this kind of format because it'll make analysing it a lot easier. But I would recommend checking the dates first to make sure that they are clinically relevant to the question that we're trying to answer. So I've definitely been caught up by this a few times by thinking that like a nice tidy data set like this is ready to go, but often it isn't. And I've got a real example on the next slide. Go to the next slide, please. So this is the example of a tidy data set we received from a well-known PROMs collection software. We have one row per patient, and we have columns for pre-surgery PROMs and also 6 and 12 month post-surgery PROMs. So I'll point out the patient highlighted in orange. I hope you can see that okay. Apologies if it's a bit small, but I'll describe it. So this patient completed their pre-surgery PROM in February 2016, and they had their surgery in May 2016. Now, Yeah, that's not on the slide because it's off the screen, so apologies. You just have to take my word for it. So yeah, they completed their pre-surgery prom in February 2016. They had their surgery in May 2016, and they completed their 6-month prom in November 2016, which is pretty much bang on 6 months after the surgery, so that's great. But if we look at the 12-month prom in the blue column, they actually completed it in September 2017, which isn't 12 months after surgery, it's actually 16 months after surgery. So this prom was put in the 12-month column because that's when it should have been completed, as in that's when its intended use was. But the patient actually completed it 16 months after surgery. So should we include this prom in the analysis? Is there a difference in the health of patients at 12 months post-surgery compared to 16 months post-surgery? So if we include it, it might skew or mislead our analysis results or the conclusions we draw from our analysis. So this is a good example of why we should really understand how our collection system collects prompts from patients. By understanding how our system works in reality, we as analysts will know what to look out for when cleaning our data. So the type of things we can think about here would be, what are patients allowed to do on the system and how do they interact with it? What aren't patients allowed to do? How many prompts can they complete? When are they allowed to complete them? Or when are they allowed to submit them? So all of these things may have an effect on the data cleaning process. So I have some examples now of different collection systems and how they might affect our analysis. Go to the next slide, please. So before I get to the examples, I'll just set the scene. So we'll aim to put a data set together to answer the following question. So is there a difference in the average PROM scores up to 2 months before surgery and 6 and 12 months post-surgery? So the anchors to guide our analysis are up to 2 months before surgery, 6 months after surgery, and 12 months after surgery. And to answer the question, we probably need to ensure that we only include clinically relevant PROMs in the analysis so that we avoid something similar to what I just showed on the previous slide. I would also want to ensure, we probably want to ensure only one PROM per anchor per patient. Otherwise, we could skew the analysis by counting the same patient more than once. Let's go to the next slide, please. So the first example is what I'm calling a rigid collection system. You wouldn't see these names anywhere else. They're basically something I've made up. But anyway, a rigid collection system is one PROM submission per invite, and where the PROM must be submitted within a specific deadline, otherwise the invite closes. So in other words, a patient has one chance to complete the PROM. If they miss that chance, then they'll have to wait until the next time before they can complete a PROM. So a good example of this type of system might be where patients are asked to complete a PROM on paper or on an electronic device during a scheduled clinic appointment. So for example, the patient might be in the waiting room and somebody hands them a clipboard with a paper PROM on it or an iPad with an electronic PROM on it. And if the patient doesn't complete the PROM at that time, then they don't complete it at all. They might only the next opportunity when they're next in clinic. So the circles in the diagram there are when patients are asked to complete the PROM. So they are the invites. And in this system, that happens to be the same time as the patient's appointments. So the red circles say could be the pre-surgery appointment. The green circles could be a follow-up appointment 6 months after surgery. And the blue circles could be follow-up appointments 12 months after surgery. Go to the next slide, please. So in this system, patients tend to complete the PROM on the same day as being asked. And that's what the X's represent there. So the X's are when PROMs are actually completed by the patient. So at the moment now, our PROMs look nicely lined up and may look ready for analysis. But referring back to the question, which mentions looking at average scores up to 2 months before surgery, it looks like our pre-surgery PROMs needs a bit more tidying. So can we go to the next slide, please? So using a time window before the surgery anchor, we can see the patient 2 completed theirs more than 2 months before surgery. So we probably need to remove that from analysis to answer this particular question. Other than that, we might be ready to go. So the strictness or the rigidness of this system makes it hard, if not impossible, for patients to complete the PROMs too far away from the anchor points in the question. Go to the next slide, please. So the next example is, I'm going to call a rigid-ish collection system. And we have one PROM submission per invite, but the PROM can be completed at any time after receiving that invite. So examples might be when a paper PROM is sent through the post and patients send it back when they're completed, or patients are sent a link to an electronic form which shuts when the form has been submitted. So in other words, a patient can't complete another PROM until another paper copy or another link has been sent to them. So the dataset may look like this time. So the PROMs can be completed at any point after the invite was sent out. So we can see that patient 3's pre-surgery PROM was actually completed after their surgery, and patient 2's 6-month PROM was completed just before the 12-month invite was sent out. So that's the green X next to the blue circle there. So we need to think about how to deal with these PROMs that weren't completed near their intended anchor points. So these examples may look extreme, but it's actually what we often see in real data sets. So to the next slide, please. So the last example I have is of a pretty flexible collection system. So there's no limit on the number of PROMs completed per invite. And again, the PROMs can be completed at any time after receiving that invite. So an example might be when patients are sent a link to an electronic form and they submit it when completed. But once submitted, the link stays open and the patient is allowed to complete and submit another PROM using the same link. And they can do that as many times as they like. So this time the data may look like this. So we can see patient 4, for example, has completed 2 pre-surgery PROMs, one just before surgery and one after. A patient 3 has completed 3 6-month PROMs. That's the 3 X's there in a row. So with this type of system, we may have multiple PROMs per anchor per patient. So once again, some PROMs may not be completed near their intended anchor point either. So I've seen data where a patient has completed a PROM every hour for 1 or 2 days after being asked to complete just one PROM. And I've also seen a pre-surgery PROM that was completed more than 2 years after the patient had their surgery. So again, this kind of stuff really does happen. So I've just given 3 examples here of different types of systems, but there may be many others that work slightly differently. I kind of think of this as being on a scale between being a very rigid system and being a very flexible system. But basically, the more flexible the system is, like this one, the more data cleaning we'll need to do before we can analyze the data. So the next slide, please. There's probably lots of ways to address this problem. And I guess it doesn't matter too much as long as we are transparent so the reader can make their own minds up. But one solution I often use is to forget about when the PROMs were sent out and to forget about how the PROMs were intended to be used and to only concentrate on when PROMs were actually completed by the patient. So we're allowed to do this because PROMs are usually licensed and the wording can't be changed in the PROM, and that's because they've usually undergone like rigorous scientific validation. So the pre-surgery PROM, say, would be exactly the same as the 6-month PROM, and that would be exactly the same as the 12-month PROM. So the questions are all the same. So that would mean that all PROMs, no matter when they were intended to be completed, are just another instance of completion. So I've removed the colours on the diagram there just to show that they're all the same. So something that may be really obvious, but I think is worth a mention, is that there may be a difference in the PROM completion date versus the PROM submission date. I know I've done it. I'm sure we've all filled in a form one day and we didn't send it back for a month later. So as PROMs usually asks about the patient's health on that day, it's always the completion date that's most important to us. Let's go to the next slide, please. So if we think of PROMs in this way, we can again use those time windows around the anchor points to identify appropriate PROMs. So in this example, I've just chosen a 2-month window. So that's 2 months before the surgery and 2 months after. sorry, 2 months before the anchors and 2 months after the anchors. So any prom that falls outside the window can be discarded because it's too far away from that anchor point. And if a patient has more than one prom within the window, so for example, patient 1 has 2 proms in the 12-month window, so that's the blue window, then we could just choose the nearest one to the anchor to analyze. So the size of this window will probably be a trade-off between keeping the most proms as we can for the analysis, but we also want to make sure that those proms are clinically relevant. So obviously the bigger the window, the more proms we keep. But the bigger the window, the less clinically relevant they become. So it's kind of, we've got to find a balance there. And this kind of thing will probably be decided alongside a clinician to make sure that what we're analysing is clinically relevant. Let's go to the next slide, please. So going back to what we originally had, I'd like you to keep an eye on patient 2's 6-month prom, which is the green X next to the 12-month invite. Look at the next slide, please. And so now we're actually using that intended 6-month prom as our 12-month prom for analysis, because it makes more sense for that to be used as a 12-month prom. So now we might be able to use the remaining red, green, and blue proms to try and answer our question. Let's go to the next slide, please. So finally, another thing that needs consideration is which type of analysis do we need to answer the question. So far, we've already ensured that we're only analysing clinically relevant proms, and we're only analysing 1 prom per anchor per patient to avoid duplication. And the question that needs answering is there a difference in scores? So because it's asking, is there a difference in scores? That essentially leads to a yes/no answer. So the next slide, please. So we could use all of these proms that we've already identified by taking the average of the red proms, the average of the green proms, and the average of the blue proms. And we could see if there's a difference between the averages, yes or no. So by doing this, we're essentially taking multiple cross sections of the data. So basically snapshots of the data. And so there's snapshots collected up to 2 months before surgery, and then again, snapshots at 6 months and a snapshot at 12 months post-surgery. And then we're essentially comparing those snapshots to see if there's a difference between them. So although this might answer the question, the approach for this is quite weak. So we're not really following patients with time here, because we're not considering any improvement or worsening of the individual patients with time. And also, as we can see in the example, we could end up with different patients in each cross section. So only patient 1 and 4 are in the pre-surgery cross section. Patients 1, 3, and 4 are in the 6-month cross section, and only patients 1, 2, and 4 are in the 12-month cross section. Basically, this kind of analysis tells us, right, our patients tend to look like this at surgery, they tend to look like this at 6 months, and they tend to look like this at 12 months. But at no point are we quantifying the change in those patients with time. The average of the green proms minus the average of the red proms doesn't give us the average change between 6 months and surgery. If we wanted to work that out, we need to calculate the gain of each patient first, and then take the average of those gains. For the next slide, please. So if we're interested now in how much the patients change between 6 months and surgery, then for patient 1, for example, we could just take the valid green prom minus the valid red prom. And for patient, but for patient 3, we can't do this because there's no valid red prom. So even though they have a valid green prom, we can't use it to answer this question. So the next slide, please. So to quantify how much patients have changed between the anchor points, we should only keep patients in our analysis with valid proms at those anchor points. And this would be something similar to a repeated measures analysis. So in this example, we need to lose patients 2 and 3. And that's because patient 2 only has a valid 12-month prom, and patient 3 only has a valid 6-month prom. So the next slide, please. So after removing those patients, we can calculate the gain for the remaining patients between those anchor points, and then we can take the average of those gains. And this means now that we're actually following patients with time, making it a much stronger piece of analysis. So the next slide, please. So just to mention one other thing using this example, and that is the number of PROMs we usually end up analysing. So in the original data set at the top, we had 19 PROMs, which were collected from 4 patients. And actually, this was a 100% completion rate. So if you notice, there's an X of the right colour after every circle. Every patient actually did respond to every invite they received. Then the middle chart, we considered how our system actually collects PROMs from patients. And we did some work to ensure that we only analyze clinically relevant PROMs. And we ensured that we'd only analyze in 1 PROM per anchor per patient to avoid duplication. And so we end up here with 8 PROMs from 4 patients. And at this stage, it is possible to do analysis with multiple cross sections. And finally, bottom chart there, if we wanted to actually follow patients with time, we'd need to keep only the patients with valid PROMs at the anchor points that we're interested in. And this would be kind of like a repeated measure study, which would be stronger. But then we end up with 6 PROMs from 2 patients. So even with a 100% completion rate in the original data set, in this example, we've gone from having 19 PROMs from 4 patients to only using 6 PROMs from 2 patients. And this brings me on to the next slide, which is not to be alarmed when cleaning our retrospective data, that we end up not using a lot of the data we've collected to answer any single question. Cover the next slide, please. So at every stage of the cleaning process, or putting our data set together, or even during the analysis stage, we'd expect to lose or not use some PROMs in our data set. So this can be a result of linking PROMs to other hospital data. So when there aren't enough completed data fields to complete linkage. Sorry, can I go back to the previous slide? Sorry, thank you. We can also lose PROMs by trying to make sense of the data from our collection system. So as we've seen, we can lose PROMs when avoiding duplication or avoiding PROMs that don't make sense clinically with respect to the question. We can also lose PROMs during the actual analysis. So by choosing to do multiple cross sections or repeated measures and so on. And also we may also only be interested in analysing PROMs. Sorry, PROMs which have a PROM summary score or an overall score. So we may lose patients who've answered some questions in the PROM, but not enough for the scoring algorithm to give them a score. And finally, if we wanted to explore the effect of a factor such as BMI or procedure type, for example, on PROM scores, then we may have all the PROMs necessary for those patients or for a patient. But if we don't have their BMI or if we don't have their procedure type, then we obviously can't use their PROM data to answer that question either. So it's rare to use all PROMs that we've collected for analysis. And unless it's like, yeah, I rarely see this unless it's like a strict clinical trial or a controlled clinical trial or something like that. So that's why we often see reports with analysis on much less numbers than the number of PROMs that was actually collected. So have the next slide, please. So as a summary, we looked at PROMs questions, and they are usually like get types or ordered category items, and they usually should be treated as ordinal data. We looked at PROM scores, which is essentially a combination of answers to individual questions that act as a summary score. The scoring process for each PROM will be different, but we usually end up with Likert scales or summated rating scales. Then we spent a chunk of time on considerations for aggregated analysis. So we considered the research question and is there any additional info in other data sets that we need to answer that question. We considered data that can be collected as a result of a prospective study design or retrospective study design. So data from prospective studies are usually easier to analyse. usually because the data was collected in a specific way to answer our specific question. But data from a retrospective study will need more work, because the decisions on collecting the data would have been made before the research question might have been thought of. And this is usually the most common type of analysis that we'll do with PROMs. And actually, this is when we should really consider how our PROMs collection system actually works as well. And finally, after making sense of the data and preparing the data set ready for the stats and comparisons and so on, there shouldn't be a surprise if there's lots of retrospective data we can't use for the reasons I've highlighted on the previous slide. So I know there was a lot of examples there, but I hope that was useful. So thank you, and I'll pass you back to Amanda.
Thank you, Rob. That was a very clear description of a very complex process. So we have one or two questions coming through. Can we start with what are the advantages and disadvantages of collecting PROMs in different ways? So, for example, paper or electronic completion for the purpose of data analysis.
Okay, so paper and electronic collections, they have different pros and cons outside of analysis. So, for example, for paper, you might need manual data entry, and the manual data entry might lead to more data quality issues. And also, you may not get a response from some patients who find that completing a paper PROM might be a bit of a faff. But in terms of analysis, the collection process will tend to be more towards the rigid or the control end of the scale that I was talking about with different collection systems. And as we've seen with rigid collection systems, you're probably going to end up collecting less PROMs, which means that it might be less useful on a patient level because you've got less data points to be able to monitor the patient. But on an aggregated analysis level, it might mean that there's much less data cleaning involved. So the data set might be much easier to deal with. And then for electronic, it's kind of the opposite, I guess. So you don't have all those issues you have with paper collection. So there's no manual entries, which means you might have less data quality issues because you can put rules around the data that you enter. But you may not get a response from some patients who have trouble with technology, for example. But in terms of the data analysis, you can have very rigid electronic collection systems, like I spoke about collecting data on an iPad in the clinic. That would be an example of that. But it's much more likely to be a more flexible system towards the flexible end of that scale. So with flexible systems, you're likely to collect more PROMs, which would be more useful on a patient level because you've got more data points to monitor that patient. But that would mean that we've got a lot more data cleaning involved before we can start doing our analysis. And then I guess the other things you could think of is difference between in-person, so like collection in clinic, and by post, for example, or by email. So again, in person or in clinic, patients are likely to complete on the same day. So the collection system is more rigid, which means less PROMs, less cleaning. If you're collecting by post or by email, for example, patient is likely to complete at any time after being asked. So the collection system is more flexible, but you might end up with more PROMs, but it does mean that there's probably more data cleaning involved.
Okay, thank you. And that leads us on to a question we're often asked around how are PROMs usually collected. And I suppose historically, as we know, PROMs were collected by paper, and we can see this sometimes by the way the historic licenses were scripted. And more we're seeing PROMs being collected digitally, and it's important to collect PROMs digitally so that can help us embed the collection of PROMs through the normal processes of a patient journey. So PROMs collection, I suppose, shouldn't be seen as something very separate. It should be embedded into that pathway. And especially where digital systems are being used, say to book appointments, then PROMs can be quite nicely be embedded into that process. I suppose we know introducing a digital system is quite complex, especially when we're trying to trigger those PROMs from automated events. So you've mentioned referral and you've mentioned surgery, for example, or appointment bookings. So the digital systems do need to be embedded and integrated with the patient administration systems within the hospital. So I suppose the answer to that is that we need multiple collection methods, which may start with text, and there may be a preference for the patient to receive correspondence by email, but there's a manual or postal or face-to-face sort of collection if that is necessary also. Okay, so I'm just looking at further questions in the chat. So is there any work taking place in industry or planned to take place to use a standard methodology for collecting scores for different PROMs?
So I think the questions are talking about the PROMs scores, the scoring I was talking about at the start. So each developer of each PROM usually provides instructions. So there are standard ways for scoring a PROM. It's just that the nature of the questions in the PROM might mean that, well, it does mean that you can't really standardize across different tools. So they will be different to each other. There are some PROM tools, like for example, there's the Oxford hip score, the Oxford knee score, Oxford elbow score, where the scoring method, so they were all developed by the same group in Oxford. And the way that they kind of use the same format for their questionnaires, so it does mean that their scoring methodologies are very similar to each other. But in general, it would be very difficult to standardize the way that you score a PROMs, just because the questions are so different to each other in each tool.
Okay, thank you. And there's another question. So you said that you see retrospective studies more frequently, but if prospective studies are easier to analyse, should we be focusing on developing more of these?
That's a good question. Probably, but I mean, because you're with prospective studies, you kind of, as I said, you've got to design your data collection for each specific question that you want to answer. So if you've got a number of questions that you want to answer, that would mean collecting different data for each question that you want to answer. Also, prospective studies tend to be, I mean, you can have observational ones, but they also tend to be like things like clinical trials, which tend to be a lot more expensive. And that tends to go into the research field then, so there's a lot of ethics and that kind of thing to consider as well. So yeah, ideally you would want to do more prospective studies, but practically retrospective studies are a lot easier to start.
Okay, thank you. And this looks like a longer question, so bear with me and I can repeat if necessary. So do the PROMs have 6 months and 12 months, etc. on the title? Could a patient fill it retrospectively? Example, so it's submitted at 12 months, but it's about how they felt at 6 months. And therefore, if it was taken as a 12-month PROM, it would skew the results negatively, assuming the patient felt worse at 6 months.
So generally with PROMs, so the actual PROMs that are released by the developers, there tends to be no difference between them. So the questions are exactly the same, and the title, it doesn't really say on the title when the patient should complete the PROM. So for example, EQ5D, it doesn't say on there pre-surgery EQ5D, it'll just say EQ5D. And then I guess you can tailor it so that it does say pre-surgery EQ5D. But yeah, you're right, it can skew the data, but it would be very difficult for the patient to complete a PROM at 12 months when they're trying to think back to what they felt like at 6 months. So generally, the PROM is completed you should consider when the PROM is completed at the time that the patient completes the PROM. So that's why we need to do all this alignment process, like I said. So there was one example there where the PROM was sent out at 6 months, but the patient didn't complete it until about 11 months or whatever it was. So yeah, it would be wrong to use that PROM as the 6 months analysis point. Yeah.
Okay, thanks, Rob. And we've got about 30 seconds left. So a very, very quick answer, if you can, to the last question. Do you assess the possibility of introduction a bias into the cleansing process, such as age or deprivation?
Yeah, so that would be, ideally we'd want to do some case mix adjustment there. So any answers that come from elderly patients, say, might be weighted differently to those coming from younger patients. There are methods in NHS England to do this, and there are models out there on NHS Digital. At the moment in Wales, we don't quite have enough data to produce our own models. And for a lot of reasons, we can't use the models used in England. So we're kind of at the stage where we're waiting for more data to be collected for us to develop our own models to adjust.
Okay, and thanks, Rob. And that brings us to the end of this session. So thank you all for listening. We do have further sessions on benchmarking tomorrow and data flow on Thursday, as well as examples from health boards around their processes and how they've used PROMs throughout the week. So thank you for listening.